Hello, and welcome to the ASRT live recorded presentation, MQSA Equip Program, Tips on Positioning. We are pleased to be joined by our instructor, Miranda Lyman Hager. Miranda has been registered with the ARRT as a radiologic technologist since 1998, specializing in mammography since 1999. After spending many years in a management role for a multi-location imaging center, Miranda decided to put down the management hat to pursue her passion of teaching. In 2017, she joined a team of instructors providing a 40-hour training course for initial mammography training. Miranda also teaches several continuing education courses and travels the U.S. assisting facilities with the ACR accreditation process and works part-time at a local Kansas City hospital where she serves as the Mammography Quality Assurance Coordinator. Miranda is passionate about teaching all things mammography, from proper positioning to proper QC, and helping technologists understand the whens, whys, and hows of efficient mammography workflow. At this time, I would like to turn the microphone over to our instructor. Miranda, you may begin.
Thank you. Thank you for joining us today. Today we are going to talk about the MQSA's Equip program, and I'm going to give you some tips on positioning. Majority of this program is all designed because of positioning. So I want to just go through the top views, the CC and the MLO, and give you some encouragement tips on how to get the best image possible. So we'll go through together. We're going to go through tips on positioning that CC view. All along my slides, you'll see photographs that I've taken, images that I've taken, and then I'm going to just kind of explain my most top tips for getting that really good CC on all different, patient shapes and sizes. We'll do the same thing for the MLO view, and then we'll wrap it up with some film critique. Just kind of look at some everyday images taken at a facility where I work, where we can go through and kind of see how we would grade them for the Equip program. Today's objectives, we're going to discuss performance of the CC and the MLO view. I want you to be open-minded to multiple positioning techniques based on your patient body habitus. So we've all learned a different way of doing this job. At the end of the day, the result comes out the same. We get a CC and an MLO view. But be open-minded to change. So that's what I want to encourage you as you listen to my tips and strategies. I want you to be able to demonstrate an ability to evaluate your clinical images and assess, have I done a good job? Have I positioned everything properly? And then know when to go back and make corrections. How would I go back and make those corrections? I want you to have a good understanding of that by the time we're done. So general positioning information, just some good reminders. In mammography, we face daily challenges. One of our biggest challenges is just ourselves versus our patient. So how are you uniquely shaped? As an individual, we're all different shapes and sizes. Some of us taller, some of us shorter, and depending on, how tall or short you are, and then how tall or short your mentor was, who trained you in mammography, you may struggle with a certain way of positioning because the way you were shown, whether you're early in your career or have been doing this a long time, is, shown to you from a perspective of somebody who was taller or maybe a little bit shorter. So you have to learn to work with where you are and be comfortable with that, and be able to kind of attack it from your perspective, whether that's somebody who's really tall or short. And then we're going to face all different, patient shapes and sizes. Some of our patients will be way taller than us. Some of our patients will be way shorter than us. In addition to that, there's all different breast shapes that we're going to find. So sometimes you go to the waiting room and get a patient, you're pleased with what you see as she stands with her clothes, but when she comes to your room and gets into her gown, she has all these different breast shapes that we're going to face. Still having to do a CC and an MLO. And so if we have any sternal abnormalities or any, large abdominis getting in the way, it's a challenge to get through. And then, like I said, you yourself have to, use your body against their body, and it can be a fight. And so that's just a daily challenge that we have to know going in. We're going to face. What I want you to understand is that there's no magic wand. No matter how good a positioning specialist is, there is no such thing as an ACR quality set of images on a patient who's 75 years old and in a wheelchair. You're going to miss breast tissue. There's going to be certain body shapes and unique features on patients that's going to create our image quality to go down, and that's to be expected. And I think even the ACR understands that and tries to give us grace where they can. Their job is to give a high set of standards and to grade us on those standards. For the EQUIP program, that's what we're supposed to use. We're supposed to use our accrediting body standards to look at the job we do every day and ask ourselves, are we keeping up? Are we doing the job that they expect us to do? It goes back to the first time we learned mammography from the beginning and all those expectations. Are we doing it? And I think sometimes the answer is going to be no, and we can't. This patient had a shoulder issue and a surgery that she just recently had, and she couldn't move her arm, and therefore we couldn't get good convex shaped muscle. And that's okay. But when we can, I think there are some things we can do to tackle some of the things we face day to day to improve the quality of our work. And we just need to know what to look for and how to approach it. So that's what we're going to talk about today. Communication is very important. Make sure you're using good verbiage when you talk to your patient and have a variety of words to use because not everybody speaks the same language. I can always say to my patient, I want you to take a side step towards me, and instead of sidestepping, they turn and look at me. And that's absolutely not what I want them to do. So then I have to change the way I say it. Maybe I say step to your right or step to your left, and that makes a little bit more sense in their minds. So just have a variety of words to pick from, making sure that you're also touching them. Physical touch is very important. So if you need her to move towards you, grab a hold of her, give her a little touch, pulling her towards you just a little bit, encouraging that movement so she really understands with verbal and touch exactly what her role is. It's important that they try not to help too much, but you do have to give them some guidance. So in the end, when we're ready to start giving those final amounts of compression, we want to make sure that she's in charge, that she says she's okay to tolerate where we're landing. If we give, though, okay for her to say, you let me know when to stop, usually we can reach taut compression with no problem. But if we're too aggressive with our compression, it can ruin our experience, and this patient can say, I'm not doing that again. So really make sure you give your patient control. Make sure you're using and knowing the mobile parts of the breast. Know where they are and move them properly. So let's talk about that next. We have fixed anatomy borders and mobile anatomy borders. So our fixed anatomical borders are those medial and superior aspects of the breast. So we really want to work with the parts of the breast that move, okay, not the ones that are fixed. So the parts that move are those lateral and inferior borders. So for the CC, we're really going to lift the breast from here, using that inferior border, lift that breast. On the MLO view, we're really going to make sure that you grab all of that lateral tissue as well as lifting from your inferior border. So we're going to use both borders. But we want to make sure that we're pulling and, lifting from all of the sections that move rather than the areas that are fixed, because we will not get those extra millimeters from areas that are fixed. The benefits of doing this is that we'll minimize that displacement process that happens when you compress. So oftentimes you lift and pull the breast onto the detector, turn on your light, and you see everything you want to see shining on your detector. But as your compression process begins, it pushes back a little bit of tissue. That's a displacement process that's real. It is not in your mind, and it's going to happen. So if you really lift and pull from those mobile borders, you'll get extra millimeters of tissue. So the little bits that you lose won't be detrimental to your overall image. So remember that each projection works together with the other one. They all have a strength and weakness. So Our standard limitation for the CC view is lateral tissue. It's expected that we're going to miss a little bit of lateral tissue. Everybody has a tail of spence. Somebody or some ladies have really long tails of spence. And of those long extensions that go into the axilla space, we're not going to get those on our CC. So the ACR told us forever and always the CC view is designed for medial tissue. Make sure you get medial tissue on your CC views. This is your best opportunity to capture it because it is a weakness for your MLO view. It's the spot that you might not get on your MLO. So together, these two are going to work as a team and give your radiologist full view of that breast. And then your radiologist is the one that says when more images are necessary. So make sure that you stand on the medial side when you perform your CC view so you can see your medial tissue, making sure you're including it. And then you know you're going to get any lateral tissue you've missed on your CC on your MLO and any medial tissue you've missed on your MLO on your CC. Let's talk about my top positioning tips for the CC view. Here are the issues we face for the CC view. We struggle to get posterior tissue visualized, so we want to make sure that we get as far back as we can. The best way to know for sure is to take a measurement of our posterior nipple line, but a lot of us will look for muscle. You're going to get muscle about 30 to 40% of the time. If you don't see muscle, one of the things you can look for is the retromammary fat space. So it's a pocket full of fat that anatomically sits right behind all of our glandular tissue, right in front of the muscle. So because it's a pocket full of nothing but fat, it often pops, out on the page for us. So when we're looking on our monitors, on our images, look for that pop of fat. Did you get it? Right behind that is muscle. So if you got muscle, then you know I definitely got good posterior breast tissue. We want to make sure that there's no exaggeration to our CCs, that you pull that breast on nice and straight. Watch your nipple as you do that. As the nipple comes forward, if it points medial, you're missing medial tissue. If it points lateral, you're missing lateral tissue. So when you're lifting and pulling the breast on, watch for that nipple point. Remove as many skin folds as you can. Make sure that you're getting good compression. And then at the end, when you really want to double check yourself, make sure that you've gotten a good posterior nipple line measurement. So on your CC view, if you measure straight back from your nipple to the end of your image, or if you've got muscle, stop that muscle. So from the edge of my image all the way to the end, 12.1 centimeters. Take your MLO view and go from the edge of your nipple back until you hit muscle. Try to find that same posterior nipple line. So don't run your angle too high and don't run your angle too low. Try to find the same straight back line from nipple to muscle, and in this case, 12.7. So we're within a centimeter, and that proves that all my posterior tissue is acquired on my CC. If I had only gotten 10 centimeters on my CC and 12 on my MLO, I wouldn't be within 1, and I would need to repeat my CC. Here's a good example. The CC view, 7.73 centimeters. The MLO view, 10.5. So not within a centimeter. So the CC view needed to be repeated. It was, and now 9.5 centimeters was able to be obtained. The downside is the nipple rolled, and the nipple's no longer in profile. Now our job is to try to get that nipple in profile without loss of tissue. So if I were the tech that did this, I would submit both images, one showing the nipple in profile and one with all the posterior tissue visualized. So here's that retromammary fat space that I was just talking about, seen nicely on this image when we've pulled in enough, not seen on this image. So as you're grading your images, looking for all the things that you need to see, and you're not seeing posterior pocket of fat, then take a measurement real quick. Make sure that you're within a centimeter. So to get all of the things that we struggle with, to have all of the positives of a CC view, here's my recommendations. Make sure that you have your patient about a half a step away from your image receptor all the time. She never needs to come all the way up against the imaging receptor by herself, or, you don't need to place her there. Always have her about a half a step back. A little further back at first to do a good breast elevation. So you should elevate the breast using that mobile border until your posterior nipple line is perpendicular to the chest wall. So as you can see here, chest wall and the posterior nipple line, completely perpendicular. So if you don't lift enough, you stand a shot at not getting all of that posterior tissue lifted and pulled forward onto the imaging receptor. Work with that mobile border and really elevate that breast. So my hand, notice, is all the way back into her inframammary crease. I'm keeping a flat hand, not cupping my hand to the breast, because that can be deceiving for how high to bring your height. So you really want to kind of level out that breast, keeping a nice flat, open hand, fingers all the way over to the lateral border and all the way back into that inframammary crease. With a nice flat hand, I like to stick my thumb out, and then I'm going to bring the height of my imaging receptor up until it touches my thumb. I don't want to bring my height too far. I don't want to elevate her breast extremely high and get down, kind of bend down and look where her crease is. We've always been taught to bring that image receptor to the level of the inframammary crease. So a lot of techs are guilty of overlifting the breast, really looking down into that crease and lifting this imaging receptor way up until it meets the exact same level as her crease. That was a good idea when we had thinner film screen detectors. Now that we have thicker digital imaging receptors, we want to kind of undershoot our height just a little bit. So just bring the detector up to the level of your hand. Your hand is living in the crease, so ultimately then you're going to give your patient some direction to bring her crease down to your detector. And this will compensate for the thickness of your detector. So with a good lifted breast, scoot your patient up until she's about a half a step away. You're going to bring your height level up until it touches your hand or your thumb. And then you're going to ask your patient to stick her bottom out and lean her chest forward, ultimately bowing her forward into the machine so that her crease comes right into contact with the front edge of the imaging receptor. As soon as she makes full contact with the imaging receptor, your job is to begin lifting up and over that imaging receptor. Don't let the bottom of the breast stick or skid across. That's just going to make the superior part of the breast kind of bow over the top and roll that nipple so that it's not in profile. You want to lift and carry that breast over the top of the imaging receptor. So she's bowing forward, you're lifting up and over, she's going to make full contact. Sometimes it's important to really get that belly pushed out of the way. So you kind of have two choices there. You can do this way, where you wrap your arm all the way around the patient and kind of tug back on her hip a little, giving her that physical guidance of tip forward, stick your bottom out, and you can smooth that belly down so that it doesn't get in the way. Or you can work from the front, where you put one hand on the belly, one hand lifts the breast, and as she bows forward, you can kind of press that belly down and back out of the way. So she just lands right in that sweet spot, and you're just going to carry that breast over the top. As soon as she's leaning, the bottom of the breast has been carried forward. Now you need to, complete the pull. We're going to use a bimanual pull to pull that breast forward. Both hands, one on top, one on the bottom. And this is a technique that's recommended by the ACR and one that I find very useful for getting good posterior breast tissue. Instead of a one-handed pull, use a two-handed pull. And then slide your bottom hand straight out towards the nipple. Don't pull it towards you where you'd be rolling the breast tissue, but slide straight out. As soon as she makes full contact, it's a perfect opportunity, and you've gotten your hands pulled all the way out of the way. You want to check for medial air gap, and this again is why it's important to stand on the medial side. If there's not full contact here, you'll have air gap, and that's an artifact that you'll have on your image. And with air gap comes unsharpness. And so you want to make sure that you don't have any air gap. And if there is air gap, you want to get rid of it. Move it out of the way. And I'll show you how to do that here in the next couple slides. So here's an example of a set of images where the technologist did stand medial, but she pulled a little too hard towards that medial side as she was pulling the breast forward. Getting her hand out of the way, she kind of pulled towards that medial side. So that pulls the breast towards the medial side as well. It begins to over-exaggerate that lateral tissue. The tech also didn't have the patient completely centered, which is something I didn't mention, but very important, making sure they're centered on the detector so that you're not clipping any tissue. So we're clipping some lateral tissue here. As I say, watch the nipple because it will point to what's missing. So this nipple line is pointing to that medial side, indicating a loss of medial tissue. And medial tissue is the most important part of our CC. Our nipple is not in profile in this image, and that is because the breast tissue was kind of skidding on its way over. The inferior part of the breast wasn't carried across. Therefore, it was sticking to the detector, and the top part of the breast, or the superior aspect, just rolled over the top and rolled that nipple right into profile. Rolled that nipple right over the underneath the breast, so it was no longer in profile. So we don't have nipple in profile. We're missing medial tissue. We're exaggerated a little bit. So we've got some areas we need to work on. So if we take the same patient, get her more centered, give her those directions of stick your bottom out, lean your chest forward, make sure she's not exaggerating her shoulders, and as we carry that breast over the top of the detector, we really lift. Use that mobile border. Lift up, carry forward, pull on with both hands, making sure that as we pull, we watch that nipple. The nipple goes straight down the imaging receptor, not pointing medial or lateral. So with a straight nipple line, now we have inclusion of much more medial tissue. I can prove that by looking here and seeing the curve of the cleavage. It's a beautiful indicator that you've got all of your medial tissue. We've got that retromammary fat space. We're including all of the lateral tissue now with no exaggeration. There's a little skin shadow artifact here, but it's a much better quality CC view on the same exact patient. My nipples are now in profile because I carried that breast up and over the detector and pulled manually straight forward. We need to watch how our patient stands as we're doing all of these maneuvers. Sometimes I think as mammographers we get kind of trapped in tunnel vision, looking just at the breast. Watch her from head to toe. Make sure that she keeps a neutral spine to the neck. Kind of bend her head down a little bit. Don't let her tip her head back. Depending on the shape of your face shield, you'll have to work with your individual units, but encourage a patient to bring her head more to the side if you have a smaller face shield. If you have a longer face shield designed for tomography, you're going to have to find that comfortable sweet spot, but have them turn their head adequately to the side with a nice, relaxed, neutral neck, not allowing her to crank her head back. This will cause an issue that I'll show you here in just a second. I like arms relaxed down by the side or lightly touching the side of the detector, and that does help rotate shoulders back and get skin folds back out of the way. Pay attention to her feet. Feet need to be facing forward because wherever the feet point, the nipple points. So we want nipples pointing straight down the center. So feet should be pointing straight and landing right in the middle. Hips back, chest forward. So when you go make your exposures, look at your patient and what did she look like? Does she look like she's standing bottom out, chest forward, head turned to the side with a nice relaxed neck? That's what you should see each time you take a picture. Again, your nipples will point to what's missing. So as you can see on this one, we've got nipples pointing to that medial side. That lateral side, indicating a loss of lateral tissue. Our glandular tissue is also running off the edge, no fat seen behind it. So we're missing lateral tissue here, and our nipples tell us that. So as you're pulling your patients forward, watch for that. Watch where that nipple goes, and it will help you. When your patients have a tendency to crank their shoulders a little bit, kind of giving you the side of interest, they also have a tendency to bring their head back, trying to get out of the way of that face shield, trying to find that comfort, placing their ear up against the face shield, and then turning their head back. Sometimes it is necessary for a complete side turn and ear plant on a face shield, depending on the face shield shape, but just keep a relaxed neck, head down and not up. Twisting the head back and up creates this shadowing effect, and this shadowing effect often shows on our image. And it's not a fold under the compression paddle, it's a shadowing over the top of the compression paddle that can be seen on our image. And a lot of techs just don't know where it's coming from. They're correcting any, folds that they see. They think everything looks good. It's just a shadow of tissue sometimes that you can see that I've circled for you here. That's what's shadowing over the top. So if this compression paddle makes full compression, then this bit of skin kind of shadows over the top of my compression paddle and gets on my image. That comes from a twist of shoulder and a head that's tilted back. So make sure you correct that. Relax your patient's head and neck. It gives her more comfort as well and gives you less artifact on your image. If you get those skin shadows over the top of your compression paddle that look like white artifacts, like this one, sometimes if you have something firm but flexible, you can stick it between your patient and the front edge of your compression paddle, and that can help hold back that little mound of tissue or skin that tends to shadow over the top of our compression paddle. Just a neat trick that I've learned in my last few years. Checking for air gap is extremely important on our CC views. So we want to stand on the medial side during the whole positioning process, but if you stand lateral, at some point come to the medial side. Very important. Look for air gap. Correct it before you compress. If there's a space between the bottom of your breast and your imaging receptor, like pictured here, you need to remove it. Unstick the breast. Unstick the abdomen from the front of the digital detector. These detectors are so thick. And as the patient advances forward and leans in, sometimes her belly will kind of stick, and it prevents the bottom of the breast from coming into full contact. So we'd have to work between the patient and our detector and kind of slide all of this tissue down and back to get rid of that air. Hold on to the breast while you do this maneuver. Very important not to lose tissue. If we leave it there and we compress, we will have air gap artifact on our image, as pointed out by the blue arrow. When we pull the breast on manually versus a one-handed pull, we are likely to get more posterior tissue and a straighter look to our CC view, keeping that nipple line coming straight down the center. We're less likely to pull that breast towards us when we use both hands and we flow forward with our patient. So it's important to recognize that while I was standing back here, even with my patient, as she began to lean forward, I took a step forward as well, moving with my patient so I could be in the position to pull the breast straight forward, not standing on the side of my patient or slightly behind her where I would have a tendency to pull that breast towards me. When we keep ourselves connected to the patient like this and only use one hand, we have a tendency to pull that breast tissue towards us and have an exaggerated look to our image. So that's just something to think of and give consideration to. Think about the breast tissue as a whole bunch of grapes. That's how I teach it when I teach anatomy. We have 15 to 20 clusters of grapes living in our breast, and we want to be able to pull all of those grapes straight forward, keeping them all in line, as separated as possible. We don't want to stack the grapes on top of each other. Our job is to try to separate glandular tissue. Lift the breast, elongate the breast tissue forward, pulling everything tautly towards that nipple. Try to keep the nipple in profile without loss of tissue, but we want to really make sure that we're smoothing everything forward, elongating all of the grapes in the breast before we add compression. That's why it's important to keep flat hands, pull everything forward. Don't cup your hands, because that's just kind of cupping the grapes together, stacking them on top of each other and giving illusions in the breast tissue, and it doesn't evenly compress when we begin to add our compression. So think about the breast tissue as you're moving it, what it's made out of. Sometimes that helps us encourage our hands to use the right motion. All right, let's talk about positioning tips for the MLO view. We want to get all that posterior tissue visualized on our MLO view as well to have the most optimal image. And that is going to mean that we have convex muscle shape that comes down to the level of the nipple. We do a best job with getting all of that muscle, the shape and the length, if we're using the correct height on our imaging receptor and the correct angle to match our patient. We want to make sure to lift that breast. We don't have to excessively lift it, just lift it enough to open the inframammary fold. If we lift too hot and heavy, crank too high, we're going to begin to get wrinkles and folds in our axillary tissue. So we want to keep all of this smooth and in contact while opening this space. So if we do a job correctly of placing her next to the machine and getting good arm placement, we can achieve this lift, just enough to open the inframammary fold without wrinkling all of this axillary tissue. Again, nipple in profile without loss of tissue, absence of as many skin folds as possible, and evidence of taut compression in the overall image. So make sure you remember the guidelines for our angle according to the ACR. We want to work with our patient's body shape. So the shorter and heavier or wider our patient is, we're going to lower that angle level down a little bit to between 30 and 40. For average, we will use 40 to 50, most of us landing at 45. And then for taller, slender patients, longer torsos, come up a little to that 50 to 60 degree range. You're going to work with your machine. Each machine is a little bit different. So, pay attention to the model you're using, take a quick measurement. Just remember, not everybody lives at 45, so you should be varying in your angles a little depending on your patient's shape. Not every tall patient is thin, so sometimes you have to back off a little bit for gravity's sake. If you have a really tall, heavy-breasted patient, you might need a little help holding that breast up, so back off your angle a little bit. Not every, short person is heavy. So sometimes for my short, little, thin, kyphotic ladies, I have to bring that angle up a little bit to get her seated exactly where I want her to get muscle. So play around with your angle. Just remember, everybody's got an angle that matches them the best. Once you establish an angle that you like, you're going to start placing her against the machine. And whether you work from the front or the back, you need to understand what you're doing when you stand her next to the machine. You should be placing her mid-axillary line right on the front edge of the detector. The mid-axillary line is just a dividing line, right behind breast tissue before you hit back tissue. So it's really situated between her pec muscle and her latissimus muscle. So we're supposed to put the corner of our imaging receptor right in that spot, correct? We're supposed to put the corner between the latissimus and the pec muscle. So we want to find that dividing line between those two muscles, simply stating, find the space of right behind her breast tissue. Don't go too far back into her back tissue, or you're going to have issues of thickness and you won't be able to achieve good compression. If you don't step her forward enough and you're not on the mid-axillary line, you're slightly in front of it, you're going to miss posterior breast tissue, not get the muscle shape that you desire or the length. So make sure that you understand what you're doing and that you're doing it appropriately. I like to put my hand on her, visually give myself a guide. Here's her mid-axillary line. She needs to step forward till the detector can live right there. I'm going to step her forward, then sidestep her against the machine, and then I'm going to work on her arm placement, which is just as important. Arm placement should be where that corner of the imaging receptor lives, basically in the back third of her armpit. So I like to lift up on all of her arm tissue. Some ladies have an excessive amount of tissue that really needs to be lifted up. Look at her armpit. Find the back third, visualize it, and then feed her back into or on top of your imaging receptor. So I always lower my height just a little bit between CC and MLO. Another good tip. You want to have wide convex shape to your muscle. Your patient has to have the ability to lean over your imaging receptor. So from CC to MLO, I always find the need to drop my height just a touch. I step my patient forward, working behind her, advancing her to that sweet spot, right where her mid-axillary line is. She steps against the machine, and then she begins to lay back on my imaging receptor like Cleopatra would. We've all said for years that the MLO view is kind of like Cleopatra. She should lay back on the machine. So you want to lift up on her arm, see the space, feed her back into it appropriately. By the time you're finished, the shoulders should be really relaxed, especially on the side that you're imaging. Shoulders on a nice straight plane. This shoulder should not be elevated in any way. Her latissimus should be visualized behind your detector. Her elbow should be nice and bent. You should see a little bit of the top of your imaging receptor here. This basically is keeping an externally rotated shoulder so that from the front, your axillary tissue is in complete contact with your detector and there's no air gaps there. So take a look at her shoulders. What do they tell you? It's like looking at a nipple line. If this shoulder is hiked up, you're going to have issues with your muscle shape. You could miss posterior breast tissue. If you have not been able to see any of the top of your imaging receptor here, then her shoulders rotated forward and you might have air gaps. So take a look at what she tells you by how she's presenting on your machine. It's important to watch the entire body as we do mammography. Here's the air gap I'm referring to. So when we have the latissimus in front of our imaging receptor and our imaging receptor height is too high, we're going to have all of this gap between our axillary tissue and our imaging receptor. We don't want that, and that's coming from too high of an imaging receptor. And the patient has rotated her shoulder forward, and she's created space. She's trying to keep herself comfortable, give herself a little bit of a cushion to lean on. So she brought her latissimus to the front. Plus, we're pushing on her, trying to get her over so we can get wide muscle. In doing that, it's uncomfortable for her. The corner is pressing on that muscle and it hurts. And so she rotates, bringing everything to the front. Now she can lean over as we're asking her to do, and she's more comfortable. So when you have patients fidgeting with their arms, rotating their shoulders all around, that's what they're doing. Try lowering your height a little bit. Then she'll be more comfortably seated with the corner in the back third of her armpit. When we don't get the arm tissue out of the way, it shows in our image quality, and it shows in the shape of our muscle when we have our height up too high. So make those corrections when necessary. Look for that on your image. Watch how our patient stands from head to toe. Both views, this is important. So we want flat-feeted patients, rotated around our machines. Look like Cleopatra, correct? So, sorry about that. We want to take a quick peek at our patient. We started behind. We asked her to take a step forward. We kind of laid her back on the machine. So does she look like she's done that? Is she nice and relaxed, laying on the machine, flat-footed, turned towards the machine a little bit, not up on our tippy toes, hovered over the top of the machine? We want to just evaluate what she looks like. When we go too far forward with our patients, advancing them too much, you can get some really great looking muscle. But in this example, this is exactly what's happened. We've got pec major, pec minor. We don't need all of that it's nice to have good muscle, and we definitely want that convex shape, and it is coming down really far. The consequences, though, we don't have good detail down here. We're having a loss of our lift because she's so far forward and she's kind of hovered over the top of the machine like I showed you in that last slide. We've got all this breast tissue that's drooping down. We can't get it lifted appropriately without wrinkling this space too much. We cannot achieve good compression all the way out to here, keeping that lift and giving us a more clean, open inframammary fold. If we balance her and step her forward just the right amount, meeting that mid-axillary line space, getting the height right so she can lean over appropriately, we can get the best of both worlds, where now we have a good convex muscle. It's still coming down as far as we need it to, but we've got that breast lifted and well compressed, and we've got a nice open inframammary fold. So we want to keep a good balance. Now that I've got arm placement, mid-axillary line placement, all of that is correct, I'm ready to work with that breast tissue. So we want to make sure, again, to keep flat hands. You can use two maneuvers, a hugging method, or if you're a shorter technologist or your patient is just too big to hug, you would come all the way to the front. I'm going to talk about the hugging method first. Keeping a flat hand, I ask her to keep her shoulder in place. Don't move your shoulder. I'm going to sweep back under the breast tissue. I'm going to sweep all the way back, and I'm going to work mid-breast, so midway between her armpit and her inframammary fold. Sweep back, flip your hand over, and keep a flat hand, flat up against the imaging receptor so you're not cupping. And then you're going to turn her into the machine a little bit, lifting the breast away from the machine as you turn her in. So you can see here, my hand is behind the breast tissue, lifting her away. We're turning towards the machine a little bit, and as I turn, I'm just slightly pulling out back tissue. The back tissue likes to come with us when we turn towards the machine, and so that's going to prevent a little bit of air gap and artifact down at that inframammary fold. I don't want that, so I want to pull out this back tissue as I turn her in. I want to turn her about 45 degrees. This is an oblique, not a true lateral. When we don't pull out the back tissue, here's the artifact. You get this vertical line fold and a bit of an air gap there. That vertical line tells you it's posterior, and the air gap is space. The lateral part of the breast was not in full contact with the imaging receptor because of the back tissue. When you pull it out as you turn your patient, it eliminates that air gap, and you have a nice in-contact lateral border. So now you'll have a nice, clean, open inframammary fold. If you cannot wrap your arms around the patient, or just in general you're a shorter technologist, then every time you would want to come all the way to the front. So you've gotten the arm in place, you've gotten your mid-axillary line placement correct, you're walking all the way to the front, and you're going to go ahead and do that breast sweep. I like to put one hand on my patient's hip so she doesn't turn away from the machine while I sweep all the way back under the breast. Use both hands to pull that breast up and out, asking your patient to turn towards the machine. You slide your bottom hand out, anchor the breast down with your top hand, and then go under the detector, right underneath, reach back to that back tissue and just pull it out. While you're pulling, you're looking. So see, my eyesight is looking right here at that inframammary fold. Is there any artifact there? You kind of have to bend down and take a good peek. And a shorter technologist has the perfect eyesight for this. They don't have to squat very far. They can look right at that spot and see if there's any back tissue impeding the lateral part of the breast from making contact. And you're just going to reach back and pull it out. Same thing I was doing when I was turning. As you compress your patient, you want to make sure to allow your patient's abdomen to be in contact with the front of your imaging receptor. This might sound like a strange concept for those of us who've been doing mammography for a long time. When we were in film screen days, we were often told to encourage our patients to stick their bottoms out and kind of pull that abdomen off of our detector. Now that we work with large imaging receptors for every shape, size patient, sometimes we have an excessive amount of detector down here at the bottom and a lot of abdomen on top. It's okay to leave it there, I promise you. If you're using a small compression paddle with a small breast, your compression paddle will hit right underneath the bottom of the breast, and none of this abdomen really is in your way. If you're working with a larger breasted woman who's taking up the entire space of your detector, you're going to be coming all the way to the bottom. And the abdomen being there is still okay. What you want to do after you've made full compression is just reopen that space by grabbing a hold of the abdomen and pulling everything straight down. So it's kind of like a finger sweep we've been taught to do through the years, but I want you to be careful not to push everything back and off. Hold her hip, slide your fingers or your thumbs straight down the abdomen, kind of following the edge of your detector. And at the very, very bottom of your detector, then you can begin to push back a little bit, and your detector will hold this space nice and open so that your inframammary fold just shines beautifully open. So try not to encourage your patient to stick her hips out or to begin pushing way back here against her abdomen. Rather, elongate that space. And that will really help you show a little bit more visible inframammary folds on your MLO views. Be careful where you hold your breast as well. You don't want to stick your thumb up underneath the breast. It's okay to just support the breast out here, more anterior, and it's hard to use the same word under, under the breast here. Don't go between the breast and the imaging receptor. So a lot of us are guilty of doing this without knowledge. We just have made a, muscle memory habit of sticking our thumbs there. Just be very careful where you stick your fingers. Okay, again, we want to just make sure to elongate everything nice and open. Here's a good visual aid for that, using fingers or thumbs. So after you've reached compression, elongate. Try not to push from way up here. All right, next on our list and last in this lecture is image assessment. So all of these tips are to encourage technologists to do good positioning. So when we are getting our equip evaluation, we are passing with flying colors. Not to mention just giving good quality imaging to every patient that comes to our mammography room. Every millimeter matters, and that's what we're fighting for the opportunity to find those breast cancers. To help us with that, to encourage this positive behavior, the FDA has said we want our imaging centers to be checking the quality of their images more often. So there is a QUIP program that is active in your facility, and somebody's responsible for checking the quality of your work as a technologist. Using a grade form, your images will be assessed at least once a year. So during assessment process of our overall images, what are they seeing about your work? So I'm going to go through a couple of examples of some images and just kind of tell you what I would say and how we can know, how we're being graded. So this, of course, is the dream. When we think about EQUIP, it's designed to meet the same standards as our accrediting body, so perfect in every way, just like we would submit to the ACR or our state for accreditation. This is the dream that we have every time a patient walks in the room, that we could just lift and pull and take a picture and everything just kind of puts itself where it needs to be. There's no wrinkles. Everything turns out exactly as it should. But the reality is we don't face those kind of patients every day. The reality is we have patients that come in that have breasts that are bigger than our detectors. They have abdomens that get in our way, nipples that don't live in the center of their breast tissue. We fight challenges, and so we have to be able to do as high a quality work with those patients as we can, as just like the easy ones. So hopefully some of the tips I gave you today will help with that. remember the air gap, okay? So when you're looking at your image, I've encouraged you to maybe not bring your height up quite so high. Working with that thick imaging receptor, we have to be careful. We want to bring it up until it touches our hand while our hand is in the crease, and then ask our patients to bow forward. As long as you don't see an extreme dip to the top of your breast, your height is right. But if you notice an air gap, you need to correct it. So again, make sure you're running your hand between the front of your patient and the detector, pushing down and back to eliminate that space. This is air gap, this dark black line. Air shows up black on our image. We have air gap here. We've pulled the breast a little bit too much to that medial side. We've exaggerated the lateral tissue, and the nipple's not in profile. Even though we've got muscle and we've got good deep posterior breast tissue, it's not the quality of image that we want to see. We want to see equal parts, medial and lateral, straight nipple lines coming down the center, no skin folds if we can avoid it. So we want to work on getting rid of some of the messiness of this image, even though there's nothing missing in this image. Look for air gap before you compress and pull it out if you can. Now, for some ladies that have really high, tight abdomens, that's going to be hard to do, and we may not be able to get rid of it at 100%. You don't want to miss tissue in order to keep the nipple in profile. So if you can't keep nipple in profile without missing tissue, don't worry about it. But pull the breast on straight. That's definitely something that we can look for. So watch what your nipple tells you. Wherever it points is what is missing. And then if you don't see it when you position, you certainly should see it in your image quality. Like in this case, that nipple line just points directly up to that lateral side, indicating a loss of lateral tissue. Sometimes, again, it's about the shape of her sternum maybe that creates that. So historically, if she's always looked like that, maybe there's nothing we can do about it. Do we need to include exaggerated? Follow your department protocols. Air gap can show up on any image, CC or MLO. For the CC, it's abdomen that gets in the way. For the MLO, it's back tissue. In order to get high-quality MLOs, remember the mid-axillary line placement. Make sure you're seating them correctly, not too far forward, not too far back. Good arm placement up and over the edge of the imaging receptor with a bent elbow and externally rotated shoulder that's relaxed. When you do that, you'll be able to get rid of this arm tissue and mound of fold here because we'll externally rotate it and softened all of this up. To get the nipple in profile, you got to do a good breast sweep all the way back to that mid-axillary line. Lift the breast away from the detector as she turns into oblique and follow the nipple. You should be able to see that as you sweep back. Where is your nipple? Is it coming to profile? If not, sweep back there again. Unstick that breast and really make sure that you're getting her into profile. And then after compression, elongate the abdomen. All that needed to be done here was just a stretch of tissue, not a pushback, but a stretch. And then you can have this. So these are the same two patients. All the changes, the positive things that I encourage you to do is what gave a higher quality image here versus here. Again, nothing is missing. We can just do better. And then look for that air gap and get rid of it. So if you can hug your patient, bring the back tissue out as you're hugging her around. If you can't hug your patient, walk around and go under the detector and pull out the back tissue. My visual aids for you, just reminding you, pull out that back tissue. This is the hugging method. Pull as you turn. This is the under the detector method. Whenever you see straight, vertical, up and down folds on your MLO, that's an indication that it's a posterior fold. A horizontal fold would be abdomen, and that would be coming from the front. And you can see those abdomens sticking out. You know you can't get them out of the way. These vertical lines are posterior, so they're kind of hiding from you. If you're standing on the front and you're not bending down low enough to see it, you don't recognize that there's something back behind the breast that's getting wrinkled in your way. And you can get rid of it by pulling it out. Be mindful of droopy tissue. So again, keep that balance, not too far forward, not too far back. And she should be rolled around the machine, kind of laying in the machine like Cleopatra, not hovered over the top. So if she stands on her toes and feels like she has to tip forward and pull her bottom out, she's going to have loss of that lift we try to keep, especially if she's got a heavy breast. So you got to lift that breast up and out, really open up this inframammary fold. And our compression paddles have to help do the work. So if you don't have flex paddles, this is going to be tricky. And that happens where I work right now. We don't have flex paddles. And so it's difficult to keep that anterior compression, keep that breast lifted. But I do think in this case, a more balanced placement of the mid-axillary line would have helped. Got a lot of little extra arm tissue up here. I love the shape of the muscle. I want to keep this shape, but I want to lift up just a little bit more and compress a little bit firmer to see if I can keep that lift. Arm placement and detector height is going to keep all of this from looking the way it does. There's a lot of things wrong. Pretty much everything I've listed today for the MLO didn't get done with this image. The vertical shape of her muscle is indicating the image receptor height was up too high. Therefore, the patient rolls her shoulder forward, creating air gap at the top, keeping her latissimus in front of the imaging receptor, and the arm placement wasn't done correctly. Nothing got lifted and pulled and really elongated over the top of the imaging receptor. So all of this arm tissue was allowed to sink into the image. Plus, because of the air gap, when you just add compression over the top of that gap, you're going to wrinkle up all the axillary tissue. The vertical shape muscle is an indication that the image receptor height's too high. The breast sweep didn't get done all the way back to the mid-axillary line, bringing that nipple in profile, and it looks as if the breast was just not lifted at all. All of these things can be easily corrected, and the very same methods that I've discussed in this lecture are what we need to use. Really lift up, use both hands, and clear all of the arm tissue, no matter how much, and make sure it all comes to the back. And then look at her shoulders. Make sure she looks like she's just nice and relaxed on top of that detector. Sweep all the way back. Lift that breast up and out. This is the very same patient with all of the right maneuvers made. So sometimes we think from looking at a set of images, oh, she must have just been really hard to do. But this patient, whether she was very difficult or very easy, somewhere in the middle, just following the tips I suggested today, we're able to get a much higher quality image on her. This is not perfect. I don't know that I'd want to send this to the ACR, but I'm certainly happy on a day-to-day, workflow to give this to the radiologist with maybe some documentation that, she had a large abdomen and I got rid of as much as I could. Here is my explanation on vertical shape, just a good visual aids for you. I've said several times already, vertical is height. When you get concave, a lot of times that comes from gripping or not using the right angle. So double check your angle, take a little hand measurement across the front of her chest, make sure you're using the right angle. But if she's gripping, holding on for dear life, that can create a caved in muscle shape. Not having enough, inadequate, she didn't step forward enough. So meet that mid-axillary line placement. And of course, convex is exactly what we want. Thank you so much for your attention today. I hope I reminded you of things that you've always known, maybe gave you some tricks that you didn't know, and that you'll go back, try these things, and improve the quality of your everyday work and get really good EQUIP evaluations. Thanks again.
Thank you, Miranda, for your presentation. On behalf of ASRT, thank you for completing this ASRT live recorded program. Have a great day.